we have to move to the next case. So I will invite Dr. Saran Marwaha, who's one of our CRY research fellows, who will present to us a case of an athlete with a dilated ventricle. Saran, the floor is yours. Thank you.
Thank you very much, Michael, for introducing me. I hope, can you all see my slides?
We're getting there, yes. Fantastic.
Perfect. Okay. So thank you very much for CRY and the panel for inviting me to present this interesting case, or I think it's a very interesting case. I'll be presenting the athlete with a dilated ventricle. Now, when we think of an athlete, or whether we're trying to exclude dilated cardiomyopathy, sometimes it's not very clear, and there's some other things that we need to take into context: family history, sudden deaths, how much exercise they're doing. And also, although we have guidelines out there, sometimes it only comes about when we have a fixed diagnosis. And the issue also becomes a problem when someone comes to us and they've already seen a clinician elsewhere. Do you go back on your diagnosis, or do you stick with your colleague's diagnosis, and do you work them up again? Now, I am presenting a 34-year-old gentleman who presents to your clinic with a letter from Australia. Now, he cycles 20 kilometers per day to work, and he's been doing this for quite some time. And that's his current exercise regime at the moment. Now, he's a traveling engineer, so he's gone from America to Australia. And he tells you that when he was 24 years old, 10 years ago, he had a routine medical in Australia where he was completely asymptomatic at the time, and his initial echocardiogram had shown an LV diameter of 59 millimeters and an ejection fraction of 35%. Now, throughout this presentation, I'm going to go with the British Society of Echocardiography findings, but obviously there's different American guidance and European guidance. So for males, 57 and above is classed as dilated. That's not indexed, but index findings, he was also dilated on that echocardiogram. And we classify less than 55 to be low normal, and up to 40 is going to be classed as moderate or above 40. So he's now in the realms of 35%, which is the borderline cutoff of basically classifying it as severe. And that was 10 years ago. He went on to having a CMR, which we didn't have any evidence of, any copies of, but it had confirmed the diagnosis of a dilated ventricle with an ejection fraction of moderate to severe with no scar. Again, he was asymptomatic at the time. At that particular time, he tells you he was engaging in mountain biking, and he was cycling 4 times a week, up to 8 hours per week. He was covering probably double the amount that he was doing now in terms of kilometers, and he was training quite vigorously. His family history consists of his paternal uncle being diagnosed with dilated cardiomyopathy, but he is alive, no sudden deaths in the family. His mother and maternal aunt have been told that they have an enlarged heart, but all of his family are cyclists and they regularly cycle. But obviously he can't tell you how intensely because he doesn't keep an eye on them. He also drinks 18 units of alcohol per week. Now, for the British guidance, that's above the limit per week. He's a non-smoker. So my question to you, this is over 10 years ago. He was given a diagnosis, or potentially not. What would you think? Do you think it's an athlete's heart? Do you think it's dilated cardiomyopathy? Or would you be unhappy with the investigations that he had? He did not have any further tests at that stage, but would you be inclined to say, no, I'm not going to have a diagnosis, I'm just going to investigate further and let him exercise at the time? So if we go to the first poll, which one would you go to?
Okay, and an audience has started voted. I noticed that Sanjay was very disappointed with that 18 units that you mentioned as the upper limit of normal. I'm not sure why.
Above normal, yeah.
It's that's a very low level.
Well, many years ago it's 24 units, and now it's 12 to 14 units.
we all have to adjust. So the audience are voting. Let's give them a few more seconds. I have to say that ejection fraction, Saran, was pretty low.
Exactly. So I think that's a very key thing while the people are voting in the audience. Often when we think of an athletic heart or grey zone, when we've talked about grey zone in the past, we talk about a mildly impaired ventricle. That's definitely more than moderate. It's going on to severe. Essentially, that is the cutoff for severe. So that is quite concerning.
And can I ask you, do we know anything about his father? Because I thought the paternal uncle had DCM, and I noted that you mentioned that his mom has a dilated ventricle, but she does a lot of cycling. Do we know anything about his dad?
No history of the father having a condition. And there's no circumstances.
So
fine.
Okay, let's close the poll. And 81% need more investigations at this stage. And only 19% went for DCM, which is probably what I would have gone for.
Yeah, I think important in this case, like I said, so these tests were done before he came to us. But I think, like Michael has pointed out, he has got an ejection fraction of 35%. That's not classic of an athletic heart. And that is quite concerning. And that's initially what he got diagnosed with DCM. So he was started on a beta blocker and ramipril. So going back to our clinic, this is 10 years on of him being on beta blocker and ramipril. They're quite low doses, about 2.5 of both, and he's tolerated them well. So this is his initial ECG. And if you will gaze at it, it's rough. He's in sinus rhythm at a rate of roughly about 80 beats per minute, but there's nothing too concerning on there. And these are his echocardiogram findings. So the measurement that we got was at 54 millimeters, and his Simpson's biplane ejection fraction was calculated at 58%. And this is on medication. This is 10 years on from the report that he was of his initial findings. His 24-hour tape with us was sinus rhythm, and he only had 6 VEs at the time.
How long was he on medications for when this echo was done?
10 years. So 24 is when.
So
so this is 10 years.
He was put on the beta blocker and the ACE 10 years ago.
Yeah, and he's continued to maintain on that medication. We did conduct a cardiac MRI. I think it's quite important to tell you he has continued to exercise. Like I said, he's doing 20 kilometers of cycling to work per day for the week, but he was doing almost double that and more vigorous at the time when he was diagnosed at the age of 24. So as you can see, if you look at his absolute numbers and look at his index numbers, it's basically confirming our echocardiogram findings that he has a normal indexed LV. But we're still saying it's subtly mildly impaired or low, borderline low. There was note of a focal patch of mid-wall enhancement in the basal inferior lateral segment. I'll go on to showing an MRI later on of but this is just the report. This wasn't mentioned on his MRI in Australia. I'm just going to point out his RV is normal. So I want to go to poll 2 now. What do you think is the likely diagnosis now that we've done our tests here in clinic? So he's got a normal echocardiogram finding. His ejection fraction has gone back to normal. On MRI, he has a normal volume of his left ventricle and a mildly low ejection fraction of the LV. Do you think it's an athlete's heart? The patient has detrained at this point as well, but he was on medication. So it's actually the detraining and the medication is just a superseding kind of factor here. So we want to take him off the medication. Or do you think it's dilated cardiomyopathy, he's improved on medication, so let's keep him on the medication? Or are you going to sit on the fence and say, it's unclear, I'm just going to monitor him? What do you think?
So let's start our poll. And when you say monitor him, continue as he is with his medication?
Yeah. But obviously be quite clear with the patient that it could be this, it could be that. It is unclear, because I think it's very important that when patients come into clinic, they often want an answer from you, especially if they've seen many clinicians before you.
I think I would certainly favor what the audience is choosing right now, which is that dilated cardiomyopathy improved on medication. I do think it brings up one important, just practical point, which is something I know we all agree with, which is could be more challenging in this case because that first echo was 10 years ago, but you always want to kind of review the images on your own. And it's all about what you see. And so, but if we're, for the sake of the case presentation, if we're going to assume that the 35% is accurate, I mean, that's just lower than what we see in athletes based on what we've seen in, with published data, with kind of 45, 50 in elite athletes, perhaps being a little bit more reasonable to consider. But at 35, it's just too low. And with the family history as well. And it looked like there was a little bit of LGE on this CMR, right? So it wasn't a completely normal CMR anyway. And so I don't think this is detraining. We also know that dilated LVs in long-term endurance athletes tend to stay relatively dilated. That's one of the findings that doesn't necessarily regress over time. I think this is just a gentleman who's been on adequate medical therapy and is showing the value of goal-directed medical therapy.
Exactly. No, excellent points there, Jonathan. Obviously, I'm going to play the devil's advocate to try and confuse the audience, and then the panel hopefully will clarify everything. And you've done an amazing job of summarizing that, Jonathan. Excellent point. We have quite a lot of patients that basically have come from another country and they'll come with reports. You may not get the imaging. So could it have actually been 35% or was it actually 40%? We don't know. We're going by the paper report that's given to us. The LGE, it's very subtle. It's potentially in the area of, someone could say, could this have been an old myocarditis? Sometimes we do kind of see this in athletes, and they've always had a normal parameters in terms of volumes and function, and we may just have, an infralateral scar there. But it'll be interesting to know what the audience thinks.
So the majority thinks that this is a dilated cardiomyopathy improved on medication.
Mm-hmm.
There is a 33% of people thinking that this is still unclear and we should monitor. Mm-hmm. And then there is just a 9% people thinking that we are in front of an athlete heart and patient has detrained medication masking, so it should be taken off from medications.
So it's important to say, although I'm kind of going to highlight this answer, it potentially, in my eyes, and when we was reviewing and over time, we don't necessarily think it's just an athlete's heart detraining, just because of the things that Jonathan has pointed out. We kind of have to err on the side of caution that his ejection fraction was 35%. And then with the family history, although it's not completely sinister, sudden death and things like, and people with ICDs, you have to err on the side of caution. And obviously he's still got a mildly impaired function on MRI of the LV, but a normal RV function. And often in athletes, we see a more symmetrical kind of, in terms of dilatation and ejection fraction. We'll, try and look at both. So we said unclear to the patient in terms of documents and possibility of monitoring, but we kept on medication. Reason being of the unclear is because you have to kind of give him the possibility, although we are leaning towards dilated cardiomyopathy, and that second answer is potentially the actual answer, you have to still leave the possibility that he has detrained, and there may also be an athletic element to it. But what we did go ahead and do is a genetic test, which sometimes is great and can bail you out or add extra information. And sometimes if it comes back negative, it doesn't add anything. And for this gentleman, he did have the Titin gene. So now, obviously...
So, Sarah, was this a disease-causing mutation?
Yeah, so he was kept on medication. and it was said that it's...
No, Saran, she's asking about the Titan variant, because obviously there are lots of different Titan variants and they're significantly typeful as well. So Sylvia is asking whether that was a definitely pathological.
Oh, sorry. Yes, sorry.
Yes,
it was confirmed pathological. Yeah. Now he comes. So now we fast forward in time, 2022. He's a 40-year-old gentleman, still remains asymptomatic, and I put it to the panel what they think of his scans now. So he comes and has a repeat ECG, which is fine. His 24-hour Holter is fine, and this is his echocardiogram now.
Sanjay?
It's definitely abnormal, and this is someone who's remained on medication, I assume.
Yes.
So he has got global hypokinesia in his left ventricle. And I wouldn't want to estimate his ejection fraction, but it looks to me, certainly eyeballing it, around 40 to 45%. It might be a bit less than that.
Amazing, thank you. So yes, so his LV diameter measured at 63 millimeters, so it has increased in size. Obviously, he was followed up between 36 and 40, but between the ages of 38 and 40, COVID happened, lockdown happened. So this is the first time we're seeing him since COVID. So his LVD is 63 millimeters, and his ejection fraction was calculated as 40%. So,
who needs Simpsons?
Yeah, he needs Simpsons. Yeah, that's experience, right? So, going further in, we questioned him. So pre-COVID, he weighed 82 kilograms, and he was cycling 120 kilometers per week, approximately 22 kilometers per day at lower speeds. So that's what he was doing, roughly 20 kilometers, 22 kilometers to work. When he went into COVID, he started training himself, and he dropped 8 kilos. He increased his kilometers to up to 190 kilometers per week. He was still doing 20 kilometers at times, but he reduced his hours to 1.5 hours to 1 hour. So his cadence increased. So his speed, his intensity had increased. On weekends, he would cover longer distances, and sometimes he could cover up to 230 kilometers. So this is COVID for him. It determined him to get back to his fitness. He stated to me that when he got diagnosed, his weight was 75 kilos at that time, when his ejection fraction was 35%. And he went back to the regime he was doing when he was 24, essentially. And so what would you do now as the clinician? He's dramatically increased his exercise. His ejection fraction's gone down. And so we'll go to poll 3. How would you manage this asymptomatic, moderately impaired, increased ventricle in terms of his exercise? Would you stop exercising? Would you allow him to continue to exercise the same amount he's doing at the moment, but increase his medication? Would you reduce his exercise and increase his medication? Or would you reduce his exercise and keep the same medication dose? Remember, he's asymptomatic and he loves sports.
So let's see what the audience thinks.
Just one question in the meanwhile for Professor Sharma, actually. Prof, would have you ever performed an echo stress 10 years ago when it was first seen with 35% of ejection fraction?
I would have, and in fact, although I would have agreed with the audience that the likely diagnosis was dilated cardiomyopathy based on the echo report we've got, I would have said we would have wanted to get a bit more, maybe a bit more information. For example, getting some idea of his myocardial reserve, getting some idea of his peak oxygen consumption, also looking to see whether he was having polymorphic or sort of high risk ventricular premature beats, just to try and support whether he's got the diagnosis or not. But yeah, I would have done an exercise echo just because I'm very interested in seeing whether our theory about whether this ejection fraction can go up by 11% from baseline to peak exercise. I would have wanted to do that for sure. In terms of what's going on here, clearly he's deteriorated after increasing his exercise load, and I suspect, assuming that the titin was a pathogenic variant, this is probably a two-hit model, that he's probably got a genetic predisposition where the stresses of exercise have actually worsened his phenotype. That's what I'd suspect. And based on that suspicion, I would have to ask him to reduce the amount of exercise he's performing. That would be my first port of call before reaching out for the medications box. He's NYHA1, he's got a non-ischemic cardiomyopathy, his ejection fraction is at very high risk, and he is already on triple therapy. So I'd want to challenge lifestyle first before going further.
And the audience actually thinks as 56% reduced exercise and increased medication, with the second most popular option, which goes gradually higher, probably because of your comment, reduced exercise with same medication dose, and a very small proportion for the other two options. So the people want to reduce the exercise, Saran.
Perfect. So he's on beta blocker and an ACE, essentially. But yeah, that's the advice that was given: reduce exercise and increase medication. Now, when you tell a patient to reduce exercise, what does that mean? And often in our guidance, we'll say low intensity, moderate, and high intensity. But for someone that exercises that much, that's extreme high intensity for the general population. But from him, it's nothing. Now, like Prof. Sharma has said, there is a risk of sudden cardiac death in dilated cardiomyopathy of 2 to 3% per year, especially where there's an increased risk if they have lower ejection fraction or a higher NYHA class. Now, he doesn't have symptoms. He's proven to increase his ejection fraction if he reduces his exercise. We've seen that already. And he also responded to medication. And there's no history of sudden death in his family. And there's no history of him having any arrhythmias whenever he's having monitoring. So what exact advice did we give him? So the plan was, obviously he's on a beta blocker, but he likes to exercise and cycle. So he may have more side effects and symptoms from the beta blocker. So you have to be aware of that if you're going to increase his beta blocker. So his enalapril was increased to 15 milligrams twice a day. We advised him to reduce back to what he was doing prior to his deterioration in his LV function, and cycle at a lower speed. Now, he knows what that slower speed is because he does his own cadence and he's got something to go back on. So it's a lot more easier for us. But it's very important to, one, talk about intensity, frequency, and distance in runners or cyclists. You can't just give them a cutoff on heart rates if they are very intense with their exercise. And we did advise him not to exceed his 80% of his heart rate, and he had a watch to monitor that. Now, like Prof. Sharma said, this is 6 years on from when he first came to us, and we now have made ways of trying to differentiate our patients with athletes and DCM. So he was brought in for a complete workup on the higher dose of enalapril to have an ECG, stress echo, and CMR and CPET. Now, if you look at the top panel, that's his resting echo. Now, this is on increased enalapril and a month's worth of reduction of his exercise. And as you can see, his ejection fraction has improved at rest. Now, I've slowed down his peak exercise, which is at the bottom, just so that you can compare, because I don't want you to take speed into account, but he was going at 177 beats per minute on the bottom panel. Now, I want to highlight to you, when you're trying to stress echo a patient that is well trained and their heart rate is, starting at 50, there's a lot of breathing artifact, moving artifact. They might be on the cycle for a good 20 minutes before you're hitting their peak because they've got so much, energy and can give. But if you look at the second cycle of his 4-chamber, his LV comes in very nicely. He has got a septal swing, but his ejection fraction seems to pick up. And if you look at the 2-chamber again and exclude the lung artifact, you can see the squeeze of the heart at peak exercise. It comes in really nicely. Like I said, this is a month after we changed his plan. His resting LV was calculated as 52%, and his peak systolic function increased to 73%. Now, we say that with dilated cardiomyopathy and athlete's heart, we want a cutoff of 10% increase or 11% increase, essentially, from rest to peak, to help us differentiate the two. But his does improve on exercise, with no significant regional wall motion abnormality, but there is that septal swing.
But can I just ask you, and Sanjay, have you tested that in people who are on treatment, and does it work the same in terms of differentiating physiology versus pathology?
I don't think, Michael, I personally, honestly cannot answer that question, because clearly the people that we've got who have got DCM, I mean, true DCM, whether it's familial or whether it's due to a virus or anthracycline or whatever, in the sort of these young people that get DCM can still carry on exercising. We've got the numbers are quite small at the moment. And I think we're going to have to, this is work in progress. And unless Sarandeep can answer more than I can, I am not fully aware of the data set and the results of what happens to people once they go on medication. But there is good data to show that, these individuals, even in the general population, that, double or triple therapy can have a significant impact on cardiac function. I suspect myocardial reserve. So I wouldn't be surprised if many of these people start to, go from an abnormal stress echo to a completely normal stress echo after medication. Yeah. What have you found, Shandy?
I was going to say that it's quite interesting, like Professor Sharma said, that obviously we're doing a larger study right now, but with dilated cardiomyopathy, that patients are majority on medication, and you don't want to take them off the medication or completely take them off the medication, because a lot of them have deteriorated in function and then come up, and there's the risk of them further deteriorating. Is that ethical? A large proportion of them, and I think even the pilot study was done on medication, and they don't pick up their ejection fraction, but no screening is 100%. And even in the pilot study, it was shown it wasn't completely 100%. There will always be anomalies. There's also the factor of essentially, we call this, and even runners use this, that cardiac training or training your heart. When you train your heart at hitting zones of between 2 and 4, where your heart rate's ranging between 60 to 70% of your heart rate, and you're training your heart. So he did essentially reduce his cadence. He reduced his distance. Has he trained his heart a little bit? Has put less load on his heart? Plus the medication increase. Has that helped as well? They're questions that obviously we need to do on a larger cohort study, but we'll try and decipher this in the future.
Sarah, we've got a couple of minutes.
Sorry. Okay, so I just want to go on to the ECG. That had not changed. The CPET had shown a VO2 max of 32.4, and his CMR had shown a mildly impaired dilated LV, but it confirmed the echo finding of 51%. We got 52% on the echo. There was no regional wall motion abnormalities. He had normal stroke volume, so that's quite important to know. And that basal infralateral scar was unchanged. So I'm just going to quickly show you these CMR pictures. So just mildly impaired, and this is very subtle LGE here. Now, the diagnosis, because of, again, he's deteriorated and he's very sensitive to exercise, he's got a pathogenic Titin mutation, the family history, the fact that the ejection fraction had gone down to 35%. I think we are swinging definitely towards dilated cardiomyopathy. But then it does pose the question, why is he picking up his ejection fraction at peak? And that's exactly what we just discussed a moment ago. But I just want to show you this slide. And like I said, we've got a true negative of exercise echocardiogram of 91% here. But we're getting sensitivities of this full algorithm of 94.1% and 83.3%. But this is the full cohort of, dilated cardiomyopathy in an athlete's heart. We're not taking into these mini cohort of patients of, are they on medication, are they not on medication, what type of exercise are they doing, how intense are this exercise, and does that all play a factor? And does genes play a factor? That's the other question in these patients. So I hope you found this case interesting, and I hope the panel, if you want to go ahead and carry on discussing.
Can I just, because we have to close, but can I just ask Jonathan something that one of our audience asked in terms of the type of exercise with those sort of patients with a dilated sort of cardiomyopathy? Would you have a preference in terms of volume load rather than pressure load? They are asking about endurance sports versus resistance sports.
Yeah, it's a great question. I mean, I don't think there's any data to really firmly answer that. I think, like with anyone, you want to have a healthy mixture of both. We know, I mean, dilated cardiomyopathy or not, having some element of aerobic exercise is going to be important. Augmenting that with resistance training, I think, would be reasonable. The one point I just wanted to add in addition, when we were talking about the exercise prescription earlier on, and you did a CPET later on, but that can be very useful in terms of guiding heart rate thresholds, et cetera. I suspect all of us, use this quite often, and many athletes, as you mentioned, very eloquently, that they don't like to just be told, hey, you cut back this percent. They like to have very much specifics, and certainly coming up with the ventilatory threshold, the heart rate at that zone, can be very useful as you kind of got back down the type of exercise that you were allowing that athlete to participate in.
Cool. I think we'll leave it at that because we need to go to the next case. Saran, thank you very much for your presentation.